Good afternoon, everyone.
Good
afternoon. I would like to welcome you to the 8th session of our weekly presentations. And today's session will be discussing about early infant diagnosis. And to assist us with the discussion is Dr. Mwangera Mubyana Mbewe from CDC, and she will be talking about early infant diagnosis, as we have become a series of topics in the pediatric group. We have been joined in the community network by a number of stations, and this includes Livingstone. And from Livingstone, this is where the case is going to be presented from. Then we've got Chipata, Lewanika, Nangongwe, Chilenje, and Kalabo. We've got a number of individuals who have also joined in the community network, who at this time are too numerous to mention. But I should mention that we've got also people in the hub who will be assisting us to discuss today's case presentation. So we shall now begin with the Dr. Mwangera Mubyana Mbewe.
Good afternoon. So the presentation for today is on early infant diagnosis. Just a correction, I'm from CIDAS and not CDC. So we are going to look at early infant diagnosis today. So the objectives for today's presentation are 5. By the end of the session, we should be able to identify the HIV-exposed infant, understand the rationale for early infant diagnosis, conduct HIV testing in HIV-exposed infants and children below 24 months of age, to understand the dried blood spot sample collection technique for DNA PCR, and also to be able to interpret the PCR results that we receive.
So our first polling question. In a breastfeeding HIV-exposed baby, nucleic acid testing should be done at A, birth or first week of life or first contact, then 6 weeks, 6 months, then 9, 12, 18, and 24 months if serology is positive, and 6 weeks after breastfeeding cessation. B, birth, first week of life or first contact, 6 months, 9 months, 12 months, and serology test done after 18 months. And then D, first week of life or first contact, 6 weeks, 6 months, 12 months, and serology test done at 18 months. So we can now vote. Green. Hiccup. So the poll has been launched. You can now vote. We are 5% in terms of custody. Okay, at least the majority have now voted, so we are ending the poll. Would you like to share some thoughts on those choices, Dr. Mumiana?
So when we look at the first choice, the first answer, testing at birth or first week of life, or at first contact, then 6 weeks, then 6 months, then you test at 9 months, 12 months, 18 months, and 24 months if serology is positive, and 6 weeks after breastfeeding cessation. I think we had the majority of the votes for that question, for that answer, sorry, and that should be the correct answer. In our new guidelines, we are testing at birth. That's an inclusion which wasn't there in the old guidelines. And we've also extended the testing to go beyond 18 months to have the last test being done at 24 months. So this repeat testing is for a baby who is testing to start, but if you have a negative test, then you follow up the testing at those particular time points until you establish the final HIV status of the infant. In the second question, you're testing at birth, first week of life or at first contact, 6 weeks, and serology at over 24 months. You can see that a lot of testing points there have been missed. If you just test at 6 weeks, if a baby gets infected along the way between 6 weeks and 24 months, then you're not going to be able to identify HIV infection in that baby. Yeah. So those are the reasons basically for the first choice being the correct answer.
Okay. So we can go back to the presentation.
So look at objective 1, which is identifying the HIV-exposed infant. How do you know that an infant is HIV-exposed? First of all, we need to understand what an HIV-exposed infant. I think we all know that an HIV-exposed infant is any infant who is born from an HIV-infected woman. So for us to be able to identify that this child or infant is HIV-exposed, we need to confirm the HIV infection status of the mother. So that's the first step. And we need to follow up all these babies born from HIV-infected women to be able to identify infection. For mothers, if a child comes with a mother of, who says that I'm HIV negative, you need to ascertain that the mother had a repeat testing during pregnancy, and this should have been done at least 6 weeks before delivery for you to say that this mother has HIV negative status. And also, if the baby is breastfeeding, if the mother is having repeat testing every 3 months, then you can say, yes, the mother is HIV negative. However, if you don't have a test done within those windows, then you will need to offer the mother an HIV test so that you can confirm if the mother is indeed negative or not. In a situation where the mother has unknown status and the mother is available, go ahead and offer a test. If the mother is not available, then you need to offer the test for the infant so that you know if the infant is HIV exposed or not. So what's the rationale for early infant diagnosis? First of all, early infant diagnosis is the early identification of HIV infection in an infant who's born from an HIV-infected woman. And we talk about early identification because we want to identify HIV infection as soon as possible after the infant has been infected. And the reason we're doing that is because prognosis can be very poor for infants whose HIV infection is not identified and they don't start treatment because we don't know the infection status. So we want to identify HIV infection as early as possible. So why the emphasis for early infant diagnosis? I've mentioned that progression can be very rapid. And the other reason is that the tests that we are using for identifying HIV infection for the infant are not the usual easy rapid tests that we use for older children and adults. You can proceed. So in terms of disease progression, if you don't identify HIV infection in an infant born from a positive woman and they get HIV infected, we have basically three groups of infants or types of progression. We have the rapid progressors who get ill very early in life, and these ones who have severe disease in a very short time, and most of the times we may actually lose them within the first year of life. And this disease is usually acquired during pregnancy or around the time of delivery. And then we have a group, 50 to 60%, who are called slow progressors. These ones will also develop symptoms early in life, but not as early as in category 1. And they may live up to 3 to 5 years of life and then succumb to HIV infection. We have a small percentage of children who are in category 3. It can range from anything, 5% to 25%, who are long-term survivors. And we need to know that with this group of children, because sometimes I think as parents who may be HIV infected and are only discovered much later and don't know when they actually got the HIV infection, they tend to think if you have a well child who is 7 years, 8 years old, then this child can't be HIV infected. And as health workers, we need to know that there's this category of children who may survive for a long time and start presenting symptoms quite late in life. So maternal antibodies are passively transferred to the infant across the placenta. And so when we do rapid tests in infants born to HIV-infected mothers, we actually get a positive test, usually to be positive even at birth. And then you can't tell if these antibodies are from the infant or they are from the mother. So you are not able to confirm HIV infection in infants based on a rapid antibody test, which is a test that we do in older children and also in adults. And these are for an infant or a child who gets HIV infected, they'll only develop their own antibodies about 6 to 12 weeks from the time that they get infected. So the tests that you need to do to confirm HIV status for a child who is less than 24 months of age or infants are based on biological tests. So these are nucleic acid tests, or we're actually testing for the genetic material of the HIV virus. Now we have point of care tests, which may be available in some of the sites that you are working from. But what is standard is the DBS, dried blood spots that we collect and send for testing at a central lab where PCR is done to identify HIV infection in infants. So this is something that we are going to look at later on in the presentation as well. But for older children and adults, diagnosis is really based on the serology test, which you can do as point of care rapid tests in the facilities. In terms of timing of HIV transmission from the mother to the infant, we have about 5% to 10% of infections being passed on in pregnancy. And then around the time of delivery, about 10 to 20% of infections are transmitted to the baby. And the rest are 5 to 20% during breastfeeding. And I must say that breastfeeding transmission will depend on how long a baby is breastfed. So the longer the baby is breastfed, the higher the chances of getting the HIV infection through breastfeeding. So we have a wide range from 5 to 20%. Infants infected in utero usually have detectable HIV at birth. If you remember the polling question, now we have included a birth test for HIV testing in infants, and that's basically to be able to identify that small group of infants who are infected in utero. And if we're going to wait for testing until later tests, we'll miss them and they may start developing symptoms before we actually do the test. For infants who are infected at or around delivery, usually they will have undetectable HIV at birth and will take a few weeks to detect the virus. That's why we want to do the 6-week test. This is basically targeting to identify these infants who are being infected around the time of delivery so that we can also pick them up early enough before they progress with their HIV disease. For infants who acquire HIV, sorry if you can just go back. around or HIV before or around delivery, disease progression can be also quite rapid in the first few months of life, leading to death. So these are the ones who fall in that first category, which we talked about earlier on. So because of these reasons above, it's very important that we identify these infants as early as possible. If you look back, the infection is acquired at different times. So those who are infected in utero, we should be able to identify the majority of them if we test them at birth, and those ones who are infected around the time of delivery, if we test them as soon as possible around 6 weeks. And later on, as the baby is being breastfed, we should be able to offer tests at the different time points to identify infection which is being acquired during breastfeeding. Can proceed. So while we are able to offer biological testing to our infants in most of our facilities, unfortunately, where we do not have point of care tests, there's always a time lag between the time we collect the specimen and the time that we get the results. So you may be faced with situations where a child under 24 months presents with signs and symptoms of severe HIV disease. Maybe you know the mother's HIV status, or indeed you've done a rapid test on the baby and the antibody test is positive. So you can make what we call presumptive diagnosis of severe HIV disease in these infants and actually decide to start antiretroviral therapy. So the main reason we are going to make a presumptive diagnosis of severe HIV disease is so that you start treatment. Otherwise, we shouldn't be doing this. So there are criteria for doing this. You need to have a positive antibody test and 2 or more of those 3 criteria. That's oral thrush, severe pneumonia, or severe sepsis. Or if you have a diagnosis of any AIDS indicator condition, a stage 4 condition, and you may need some supportive, if you have other supportive evidence such as recent maternal death or advanced HIV disease in the mother, or a low CD4 percentage in the infant, then that will all support your diagnosis for severe HIV disease in an infant and start treatment. But even as we do this, we must remember that this is not confirmatory. So you need to immediately collect your specimen for HIV diagnosis, for the nucleic acid test to confirm HIV infection in the infant, and make sure you follow up the results so that you get them early enough to confirm HIV disease. Can proceed. So that's just a diagrammatic representation of the presumptive diagnosis of severe HIV disease in a child who's less than 24 months. So you need at least 2 of those symptoms: oral thrush, severe pneumonia, severe sepsis, in someone with a positive antibody test to make the diagnosis. So for conducting HIV testing in HIV-exposed infants and children less than 24 months, there are different time points. I think we've talked about this. There's the birth testing, the 6-week and 6 months, which is based on nucleic acid testing or collection of a dried blood spot. And then the follow-up test, you need to do a serology test first. And if it's positive, then you proceed to do a nucleic acid test or collection of DBS to send to the lab to confirm the HIV infection. We'll briefly review the techniques for dried blood spots sample collection. Basically, you need to have all your supplies ready, your gloves, your lancets, your cards, and make sure they're well labeled. Have the heel of the foot of the baby warmed if it's very cold. And those are the shaded areas. There's the sites on the foot that you'll be targeting to prick for the collection of the sample. And you clean the site with alcohol, allow the area to dry so that it's not wet. If you have some wetness from the spirit, you can get some spoiled blood spots where you have all those yellow rings showing. You may need to wipe away the first drop of blood. Apply the blood to the slide on the printed side of the paper only, and do not layer successive drops of blood. Just apply 1 drop of blood per circle on the card. and avoid touching or smearing the spots. So those are the basic steps that you need to take to collect a DBS sample. And before you send to the lab, make sure it is well dried and packaged properly as per guidance. This is just an example to see what is what you need to have an acceptable DBS. It's unfortunate we have quite a number of DBSs collected where we don't get results because the sample was rejected. So we need to make sure we do this properly. So an acceptable DBS should have proper identifying information written on the card, and you need to have at least 3 good spots collected for it to be acceptable at the lab. Avoid layering as mentioned earlier on. You can just go back a bit. Sorry, yeah. And then these are some of the reasons that you get a rejection of your DBS samples when the identification is not clearly written on the specimen, on the card, or you are collecting very little blood. If you look at the second column, you have those small rings in the circles that may result in a rejected sample, or you have layered or clotted blood, which is in layers and it's very dark, or you have all those yellow rings surrounding the blood circles due to too much alcohol and you didn't dry it properly, or maybe you were squeezing the foot and squeezing out tissue fluid, or you were using a capillary tube and you're touching the tube and you get all those small dots and scratch marks on the card. So your sample will not be processed, and you'll get, when the results come, it will just be saying a rejected sample. So try and make sure you have a sample that is well labeled and collected properly so that you get your results. So when you get your DBS results, it can tell you that negative or undetected. This means the baby is not HIV infected. Or you get your results saying it's a positive result, meaning the baby is HIV infected. And when you get a positive result, you have to make a decision now. You need to start treatment. You are not going to wait to start the treatment. So you make a decision, you start treatment, and immediately you should collect another specimen to confirm HIV infection status. But you will not wait for the results for the second sample. You will go ahead and start treatment as you wait for those results. Sometimes you will get an indeterminate result. If you send enough spots on your cards to the lab will actually go ahead and retest your samples to try and confirm if there's HIV or not. And this is usually due to, there may be detectable HIV, but the level of the virus is too low and it could potentially be a false positive result. So you'll get an indeterminate result. If you ever receive such a result from the lab, you need to immediately call back the infant and have the samples, the infant sample recollected and sent back to the lab. Sometimes when you send your second sample for confirmation, if you had the first positive test, you may get a second negative test. So that's what we call a discordant result. In such a situation, you would need to collect a third sample and send back to the lab. So if your third sample is going to come back negative, then that child's probably HIV negative. If it's going to come back positive, then you need to continue treating the baby as positive. So right now, I think we have reductions in mother-to-child transmission rate with the various interventions that we have. So with this reduction, the confidence in the positive result is actually reduced. If you look at those 3 pictures, in the second one, we have 20% mother-to-child transmission. When you get your results, you almost have 100% confidence that the positives are positives. When you get to a situation where you have 10% mother-child transmission, out of all those samples, you may have 1 false positive. If you have 5% transmission, you can actually have 2 false positives out of the 100 samples. And where you have very low transmission, 1%, you have quite a large number of false negatives. So in our environment, I think I just want to stress that it's very, very important to send that second sample for confirmation of HIV infection, especially with the reducing mother-to-child transmission rate. So if you look at those graphs there, Zambia, we have about 4% transmission. That should be in utero. Where's my key? Sorry. And then 6%, no, sorry, not transmission, not in utero. 6% during breastfeeding transmission. And then, 4% earlier on perinatal transmission. So we have quite low transmission rates. If you think back at those diagrams we're looking at, we should be having quite a few false positives if we are not sending back specimens for confirmation. We can proceed. So that was early infant diagnosis. In summary, the key points we should remember: we need to follow up all infants born to HIV positive women for us to be able to rapidly identify the HIV exposed infants and confirm HIV infection status. Testing time points to remember for HIV exposed infants: we need to test them at birth, at 6 weeks, at 6 months, at 9 months, 12 months, 18 months, and 24 months. And then if they stop breastfeeding, 6 weeks after they've stopped breastfeeding, with the first test up to 6 months being a nucleic acid test. And from 9 months onwards, you need to do a rapid test first. When it's positive, you proceed with the nucleic acid test. The other key point you need to remember is to initiate ART with the first positive nucleic acid test and collect immediately a confirmatory sample. We do not wait for the results of the confirmatory sample to start ART, but we need to start treatment immediately. In a situation where, unfortunately, you don't have the results with you and you have a very ill infant, you should be able to make a diagnosis of presumptive, diagnosis of severe HIV disease and start treatment, but make every effort to collect a DBS sample and confirm HIV infection status of the infant.
Okay, thank you very much. So we are going to the second poll question, and it is as follows. The following may cause invalid DBS samples, except the following may cause invalid DBS samples, except A, inadequate sample, B, layered sample, C, using 1 drop of blood per cycle, D, yellow rings around the blood. So we can go ahead and give our poll.
What's the answer? C, I think is
the poll is in progress. We can go ahead.
This is the answer based on the presentation.
Nangongwe, would you please mute your microphone? Okay, we've got a majority who have voted, and I think about 14 have gone for option number C. Would you kindly say a few words about this result?
Yeah, I think this is very clear from the presentation where we showed the reasons for an invalid sample. If you have a few drops of blood on your dried blood spots on your card, DBS card, then it may be not adequate for the specimen to be processed, so it will be invalid. If you are applying blood more than once, you get a layered sample, again, it may be sent back to you as not being able to be tested, so it will be invalid. You need to make sure you get 1 good drop per circle instead of having several layers of drops for blood. So that option is the one I think most of us have chosen. So that doesn't give you an invalid sample, but it gives you a valid sample. And then you get yellow rings around your dried blood spot, which could be due to spirit or too much tissue fluid. Again, you may get an invalid sample, so it won't be processed. So as we are collecting our specimens, let's make sure we look out and don't have those reasons that will give you an invalid sample.
We can proceed with the presentation. So yes, that was the end of the presentation on early infant diagnosis. And I can see already some hands for clarification. We'll get the first question from Chipata. Chipata, can we unmute Chipata?
Yes. Good morning, everyone. Good afternoon, everyone.
Good afternoon.
Yes, I'm Kabala from Chipata. I live Menta, Petauke and Nimba. My question for clarification, I've got a question for clarification. The first one, I want to know, why should we wait for 6 weeks to collect the confirmatory after breastfeeding? Why should we wait for 6 weeks? And the second one, is the PCR a quantitative test or a qualitative test?
Okay, thank you very much, Kabala from Chipata. And I think the two questions, Dr. Mianambeo will be able to address them. So the first one is, why wait the 6 weeks after cessation of breastfeeding? And then the second one about the PCR being either qualitative or quantitative.
Thank you for the questions. For waiting for 6 weeks after complete cessation of breastfeeding, remember when you get an HIV infection, if you get infected today and you are tested for HIV, we may not be able to pick up the antibodies or even the virus. It needs some time for the infection. If you are doing a serology test, it will need time for you to mount an immune response and be able to detect the antibodies. Even for the virus, it needs time for it to multiply for you to be able to pick it up. So we do have that window of 6 weeks to wait before we can do a test to be able to detect HIV infection. For the PCR question, the DNA PCR that we are using is qualitative. So it will just tell you that it's positive or negative. HIV genetic material has been detected or it hasn't been detected. So it just tell you whether it's there or it's not there. It's not quantitative. But when we are doing the other PCR that we do to use HIV infection is the DNA PCR, which is qualitative.
Thank you very much. I hope, Kalabo, the responses given have been clear. We've been joined by our colleagues from Tanzania, specifically Bugando and Mwanza area, and they have been following the session. So the next question is from Sivongile. Sivongile, is it Shonge? Sorry, Shonge. May you please turn on the video so that we can see you?
Sorry.
Good afternoon.
Wait. Good afternoon. This is
Good
Sean
afternoon.
from Livingston. I've got here with me. By the way, Mangero, that's a very good presentation.
Thank you, Sean.
With PMTC as our PMTC midwife in Kazungura. She's got a few questions for you concerning the resulting.
Yeah, good afternoon. This is Mildred. We've got.
Kindly lower your camera, we can barely see you.
Okay. Hello?
Hello, yes, we can get you.
Okay.
Correct.
Yeah, this is Mildred. we've got two ways of receiving results. Some results we receive by Program 1, others we receive by hard copy. And Program 1, yes. But we faced resistance when the results are sent by Program 1. You find the healthcare workers don't initiate. They will wait for the hard copy, no matter how long it will take. We need clarification on that one. Then the other question is on follow-ups. It's we've observed that follow-ups are not really happening in the facilities. Maybe you can help us. What good practices can we put in place to really make sure that we follow up these babies in the facilities? Thank you.
Thank you very much, Madam. So I will ask, I think even Dr. Moya can come in with regards to program 1 and most providers having the inertia to initiate. Is it because we don't trust the result, or what really could be the problem with the results that are coming from program 1? So probably Dr. Mwangera, you can comment, and we can ask Dr. Moya to comment on that as well.
Thanks for the question. Yeah, indeed, we have also faced challenges in terms of healthcare workers acting on the results sent through program 1. I think we just need to educate our colleagues. They are valid results. If they need hard copies, I think you should be able to print if you have printers, but they are valid results from the lab, and we need to act on them. And if it's positive, collect a confirmatory specimen and start the baby on treatment. So I think it's just an awareness issue, and also following up to make sure we have hard copy results on file for the patients. I'm sure others in the room can add to that. In terms of follow-ups not happening, what are some of the good practices? I'm sure, again, there are others in the room who add to that, but some of the practices that we have seen work is trying to pair pregnant women with a counselor from the time they're pregnant until the baby is born and until you've confirmed HIV status beyond up to 24 months. So that is a practice which, if we are able to implement, is actually quite helpful. It may be a challenge if you don't have enough counselors, but it's something that has worked in places where they have used it. There are other practices like trying to see babies together with their mothers at all the visits. That may work in some areas, sometimes it may not work, but indeed it's a challenge. But the other thing that we need, I think, to try and work on is that, these babies do come for immunization activities. So I think we need to sensitize our colleagues who are working in under 5 clinics and conducting the EPI program to try and make sure they capture and identify these infants who are HIV exposed, particularly making sure that on the under 5 cards is indicated and that the exposure status is actually indicated for each infant, so they follow them up at the various time points. Because when you look at children's cards, you find that they come for weighing throughout, but somehow they are missed for testing. So we need to sensitize and really work hard to try and identify these children who need to be tested at those various time points. I'm sure others in the room may have things to add on.
Thank you very much. Any thoughts, Dr. Moya?
Okay. The last point Dr. Mbiana mentioned on the good practices, I think, like Charles said, under 5 or MCH, right now the program is such that all the under 2 years who are HIV exposed are followed up in MCH. Okay? So that to make sure that those kids, when they come for weighing, the appropriate tests are done. That was why it was designed in that way. So that is one of the good things that can be done. And then secondly, please, good counseling, like Charles said. That's very, very important, so they understand why they have to have their babies tested. It's for the benefit of their own children. So good counseling is the only way out. Otherwise, if they don't understand, then there's no way that they can come back. So it's just good counseling. And since they come for under 5, then they can be tested appropriately up until they are after the age of 2 years.
Thank you very much. There's another contribution. Is it a question? Thank you.
Thank you very much. For program 1, for us to expedite result receiving, we can also use a thermal printer. So we can order these from medical stores and train healthcare providers. As soon as you receive the message on your phone, you can command the printer to print. Especially for high volume sites, you may need a printer in place. Thank you.
All right, so this is for all program managers, and I think HIV mentors. So what? Okay, you can
just a comment on program 1. Like the other 2 have said, it was designed to have results reach the health facility as quickly as possible. Because remember that if you're using hard copy, it takes 6 months sometimes for the health facility to receive the results. And in the long run, we have children dying because of this delay. So in order to expedite the results going quickly to the facility, this is how programs like Program 1 was done, so that at least you get your results as early as possible. There's another program we had where they were sending SMSs to your phone. Again, it was in a bid to ensure that results are reached facilities as quickly as possible so that children are started on treatment as early as possible. So the healthcare workers, please let them trust the results. They are authentic.
Program 1 was meant that we receive these results faster, so we should trust these results. And then there's also a suggestion that we could actually order thermal printers from medical stores which are available. So all HIV mentors, please kindly ensure that you liaise with the program officers in your districts and provinces so that we can see how we can get these printers so that people who are used to hard copies can indeed access them. And I think there's a contribution from Mong Urban, which is actually trying to
on this.
Sorry, can you mute your microphone? Sorry?
Just a comment.
All right.
Just a comment on the same issue. Why don't we have someone write this as a memo and then all healthcare workers will follow it rather than this program 1. Rather, we've been talking for years, but no one, it's not coming up. Let's put it in black and white.
All right, thank you very much. And we have picked it up from the hub. So Mongo is also saying, making an appointment, register for the baby mother pair to give the exact dates for the mother to bring the child for test. If they don't show up, then we make a follow-up. And this is what has been suggested, that we pair them to different counselors. We are now going to have a case presentation for the day, which is being done by Agre Mambo from Livingstone. Please, if you can be ready to share your screen and the case presentation. Agre is a clinical officer mentor who is based at Kazungula, and he's presenting from the Livingstone Eco Network. So Agre, you tell us when you're ready to share, to start the presentation.
Hello, good afternoon.
Livingstone.
Hello, can you get
me? Good afternoon. Yes, we can get you.
Okay. So our presentation is from Kazungula Rural Health Center. So we'll start with the mother-baby pair history. So okay, our slides are a little bit slow. You bear with us. So his mother is a 23-year-old, para 2, attended antenatal care at Njola Mwanza Rural Health Center in Monze. Was tested HIV positive at 6-week gestation, but was not commenced on ART. She only started ART on TOD, that was 10 months ago, 3 days before she delivered. The baby received single-dose nevirapine from birth. The husband was later on followed up for index testing. He was a non-positive and was on full ART. So the baby is now 10 months old, was born on 16 February 2018. DBS was done when he was 3.5 months at Kazungula, and it came out positive. At 5 months, was commenced, that's the baby now. At 5 months, he was commenced on ART, on the regimen AZT, 3TC, and Kaletra, up to date. Actually, he is still breastfeeding as we still discuss. He has an older sibling who tested negative as well when he was followed up for index testing. So on physical examination, that was at the last visit, the mother's temperature was 37.3 degrees Celsius. EP was 111/65 with a pulse of 88 beats per minute. The rest of the examination was otherwise unremarkable. Then the baby, the weight was 7.2 kgs. The rest of the exam unremarkable as well. So on the mother, the tests that were done, the HIV test was done. That was October 2017 when she was 4 months pregnant. She tested positive, but was not initiated on ART. There's no available documentation as to why she was not initiated. And she only initiated on 13th February this year when she was 9 months pregnant. She was initiated on the regimen TLE. On 22nd March this year, CD4 count was done. It was 1,135. And mother was commenced on cotrimoxazole and INH. In July this year, 2018, she was due for viral load, but it was not done. There's no viral load in her follow-up to now. So, then for the baby's results, at birth, DBS was not done. However, single-dose nevirapine was commenced. At 6 weeks, DBS was still not done. Cotrimoxazole was initiated. When he was 2 months old, DBS was collected. It was sent on the 6th of April this year. Results were positive, and they were received on the 8th of June this year. At 3.5 months, DBS was collected again. It was sent on 27th May and was received on 28th June. However, the results were still positive. Then full ART was initiated on 20th July 2018 on the same regimen AZT3TC and Aletra. So on our questions, we've got 3 actually. The first one is, should we switch to ABC3TC Aletra at this point, or we maintain the current regimen they initiated on? Then the second one is, what are the implications of long turnaround time for DBS on patient management? Then the last one on the mother, should TLD have been considered for this woman when she was tested? That was at 16 weeks gestation, or on initiation when she was 40 weeks. Thank you. We can't get you.
We are now inviting questions. You can now mute from there, Livingstone. We are now inviting questions or clarifications from anyone in the network or any member who is present in the hub.
Can I clarify on the infants prophylaxis? You said single-dose nevirapine was commenced. Was it 1 dose given, or they gave nevirapine for 6 weeks? It wasn't very clear if it was just a start dose. or it was given for several days?
Agre, could you pick it up?
Actually, it was not. The child was given NVP to continue, not just there and then to stop. No, the child continued on NVP.
Okay, for 6 weeks.
For how long was the NVP given?
For how long? It's not really documented. It's just written in the DPS register. The child was given nevirapine.
Okay, thank you.
Any other clarifications? Either from here, the hub, or the community network? Chipata, are we clear with the case? Dr. Foloshi.
Question.
Yes, Harry.
So thank you for this case. I was wondering if you know, just from reading the chart, was there ever any concern about the health of the baby? Like, was the baby growing well, feeding well, thriving without any problems? And the reason I'm asking is it seems like the lab system might not have come through for this baby. So I'm wondering if there might have been a role to consider what Dr. Mubiana was describing, the presumptive treatment of HIV. Like, was it a high, I think from the history, it seems it was a high suspicion, but from the clinical presentation of the baby, was there ever that kind of a concern?
Livingston, you can pick it up.
Okay, on that one, from the registers, you can hardly tell, because if you remember from the history, in the first place, this woman was attending antenatal care from Anjola Mwanza in Monze. So it's like she was just collecting her drugs from Kazungula, and that's where the child was captured from. So on that one, the registers couldn't really tell.
Yes. Chipata, your hand is up. You can go ahead.
I would like to know how long the husband was on ART.
Chipata, are you done? Okay, I think
You
the
get
question.
my question. I want to know how long.
How long the husband was on treatment?
Yes.
Okay, I think we got you. Before we go to Chilenge, Agre, would you want to give any thoughts about how long the husband had been on treatment before the birth of this child?
Actually, on how long, it's unclear as well. Unfortunately, we couldn't ask because we are just phoned in. But the time the team went for index testing, the husband said he was already on ART.
Okay, thank you very much. Chilenge?
Thank you, Dr. Mupet. Are you able to hear us?
Yes, although with difficulty. If you could move slightly closer to the microphone.
Okay, I know that our objective is to eliminate the transmission of HIV to the new COVID. Yeah, now that we've been told that the HIV diagnosis was made when the woman was 4 months pregnant. I guess that she refused to be commenced on ART. Was there any follow-up in terms of adherence counseling to prevent the transmission of HIV to the infant?
All right, thank you very much. Although we've been told by Agri that the information is a little bit scanty, I think Chilenge has tried to assume that this woman refused treatment, although we have not been told about that. Anyone who can give thoughts on that? Yes, from the hub.
Not a thought as such. Yes, the woman refused treatment, But many times, as healthcare providers don't offer an option. We could go maybe counsel a woman on option B, which she can take during pregnancy and during breastfeeding, and thereafter, she can stop. But in between, you continue with the intensified counseling so that in the process, the woman can even, decide to continue taking ARVs for life. It's a component that is missing, and it shouldn't be given in a general health education, but on a one-to-one counseling.
Okay. Thank you very much, Livingstone. And please, before you come in to give your comments, kindly stop sharing your screen. Agree.
Okay.
Thank you.
All right. My name is Robert Banda, and we are co-presenting this case with Agri. So maybe one thing that may be of note, which unfortunately didn't come out during the presentation, is that this woman is usually mobile, and that's why we have her coming from all the way from Monze and collecting her medicine in Kazungula. So we are not so sure how exactly she may have but I think that's the opportunity that we would have taken, especially that she's always almost on the move. I think that's my thought on that one.
Okay, always on the move. Is she a trader or it's part of something else? What do you mean?
She's actually a trader, so she crosses through Kazungula, and that's why she collects her medicine from there. And it was at that point where it was thought, due to the frequency to the facility, it was thought that she's followed up from there instead of Monze.
Thank you very much for those clarifications. I think we can now look at the specific questions that Agri and team had. Sorry, there's a hand. Sorry, I cannot seem to find Nangoma. Nangongwa, sorry. Nangongwa, you can go ahead.
Thank you very much. Good afternoon, everyone. We have two questions for the case study. The first question is, why was single dose developing the only prophylactic drug that was given to the baby? And the other question is there any special reason as to why the child was started on AZT3TC lopinavir instead of ABC 3TC lopinavir? Thank you.
Thank you very much. Livingstone, could you kindly pick it up? Agri and Robert.
Okay. For why the baby was just given NVP alone, it's not as well documented. But that's what was found when we went through the case. The child was only given NVP alone. And for AZT3TC lopinavir and instead of ABC3TC lopinavir, as well, there's no documentation as to why it was given that way. Thank you.
Okay, thank you very much for the clarifications. Livingstone, you can mute now. We have, I think, the last question from, is it Chipata? Chipata, yes.
My question is, I'd like to know what happened. What happened between 16 weeks and 40 weeks in terms of follow-up? If she was attending, was the adherence or cancel done to initiate the ART at any point after 16 weeks of diagnosis?
Okay, thank you very much. Quickly, Agre, would you give some insights what happened between 16 and 40 weeks if the mother was attending antenatal or she was lost to follow-up during that period?
Okay, on that one, I think it would be a little bit difficult to answer as well because there's no document. Since they didn't document as to why they didn't initiate at first. So we're just assuming maybe she was refusing until she agreed when she was 9 months. But all in all, nothing was done for the follow-ups.
All right, thank you very much. Lewanika, you will be the last contributor on the case. Lewanika, you can go ahead.
Why DBS was not taken place? Was it a home?
Sorry, Lewanika, you are far from the microphone.
Good afternoon, everyone.
Good afternoon.
I'm Lucy Samba. I just wanted to find out why the DBS was not done at birth. Was it a home delivery or a facility delivery?
Why the DBS was not done at birth? Yeah. Agre, would you pick it up?
Yeah, on that one, I think she just came late during the presentation, but I earlier on said DBS was not done quite right, and it's not documented, but MVP single dose was the only thing that was given.
Okay, so like Agri has said, information extraction in this case is very, very difficult, and they cannot know exactly why it wasn't done. Chipata.
Yes, this is Dr. Lusa. My contribution is that when going around for site assessment, we had also a child exposed on single dose nevirapine. So it's possible people out there are not aware of 2018 guidelines. We should mentor them. That should be a gap to be filled by the mentors, both for prophylaxis and ART. Thank you.
Thank you very much for that, Lucy. Duncan here in the hub.
Thank you very much, Robert and Agre, for that presentation. My name is Duncan Chanda. I think this case brings in a lot of issues around the quality of care. And my question would be, were efforts made, not by you necessarily, but to inform the program to try and investigate why this case seems to have gone completely wrong in a lot of areas. I think we cannot continue making speculations. What would be prudent is to send a team which is nearest to that health center and investigate how we got here. You might find that this is the standard practice in that health center, and you just happen to have come across this patient yourselves. I think it raises a lot of issues around the quality of care.
Thank you very much, Dr. Chanda, for that. Now, I think it's time that we now discuss the questions that have been posed for today. And the first one is, should we switch this child from to ABC3TC lopinavir from the current regimen that is on, which is AZT-based? Dr. Mang, any thoughts on that?
This child has been on treatment for 5 months, I think. And they chose to use AZT3TC lopinavir, which in terms of AZT, we should be reserving for our second line, which for someone who's been on treatment for a few days, I think I would consider switching so that we preserve the second line drugs for second line at a time when a child fails treatment. So I would consider switching. That's my view.
Any other thoughts from the hub before we allow the other people to join from the community? Dr. Moon? Dr. Zico?
Okay.
There's another aspect which is worrying concerning this case. We are informed that the husband, is it, or the partner, has been on ART for a long time. We don't know how he's faring. And also I noted that we don't have a viral load on the mother up to this time. Is it conceivable that she could have a resistant virus at this point? Given that the husband has been on ART for a long time, that's what we are told. I think it would be prudent actually to investigate whether he's suppressed and whether she's suppressed at this time. She has been on treatment now for more than a month, for more than a year. We missed the 6 month viral load testing, I note that. And we don't have any viral load on her right now. So my opinion would be, before we start treating around even the child's regimen at this point, there are too many loose ends which need to be looked into. Yeah.
Okay. Thank you very much, Dr. Chanda. And I think the consensus from Dr. Chanda is the issue of primary resistance transmission. We know that this mother's viral load is uncertain, and equally the husband to the mother as viral load is also uncertain, and it's also unclear for how long he was on treatment before the conception of the child. So any thoughts on that? Dr. Foloshi from Chipata, any thoughts on switching and the concerns for primary resistance?
Hi, good afternoon, Dr. Mpeta.
Good afternoon.
Okay, I'm glad you can hear us from Chipata. I think, as Duncan has said, I wouldn't really rush to switch the child. I would actually advocate for a viral load and even a genotype in this child, because right now we are now limited in what we can go to next. So we have to be very careful with the next steps, especially remember the child is single dose nevirapine exposed. Mom is TLE, she seems quite mobile. We actually don't know how adherent she is because she seems to have been lost in the system. But even more concerning, which we have seen as we've done granular site management, is the turnaround time for that DBS. It looks like it came back on time and really it's not clear what happened. And this case speaks to the importance of documentation. When we receive a client, we need to be responsive and document everything, even if we feel a lot of wrong things have been done on the child. So the records are not clear. So for now, I think as we need to be very holistic, bring dad in, bring mom in. We don't even know how child is doing on this ART. Could even easily be failing. So I think that's my contribution. I think we really need to go back to the drawing board. And I think that's up to Agre and Robert, they work in Kazungula to look up on how this child ended up in this situation. Thank you.
Thank you very much, Dr. Foloshi. So there's the aspect of concerns for primary resistance in this child, which has to be investigated and to ensure that the child is not having any resistance. Otherwise, we will be limited in the options that we have. I can't see any other hand on this. Livingston.
Yeah, it gives me, sort of a blue feeling listening in.
Sorry, Dr. Fubisha, any way you can move closer and closer to the mic?
I think I should. So it gives me a blue feeling listening in. I mean, I think this case is really mishandled, and I think both parents again are not in the, were not again looked at with the quality that we have been talking about all the time. Now, I totally agree with the last two comments. We have to be very careful. I think we shouldn't change. Let's do a viral load, and then, if anything, do the genotyping. Then we can, switch with good evidence on our fingertips.
Thank you very much, Dr. Subisha, on your thoughts. Where's the second question? We can now, and I think it's consensus now that we will not switch or rush to switch until we get the viral load for this child and possible resistance testing because of a number of issues with regards to single dose and Nevirapine exposure, the father whose treatment history is not very clear, and also the mother who seems to be mobile with unclear, history and place, fixed place of abode. So the second question is, what are the implications of long turnover time for DBS on patient management? And I think this has been, highlighted by the previous speaker in Dr. Foloshia and Dr. Fovisha. Any quick thought about that, and how we can just encourage, the community on that? Yeah.
Yeah. So I think this child had waited 2 months from the time they diagnosed until the time they started treatment. From the testing, it appeared they did the test in April. So they didn't get the results. In May, they collected another sample. And they got both the results in June. That's when they started treatment. So as discussed earlier, for infants, it's difficult. If a child may progress rapidly, and it's difficult to tell if they will progress rapidly or not. But if we delay treatment, really, you are just increasing the chances of a child not of the child getting ill and deteriorating. So I think we have labored on this. It's very important to make a diagnosis early so that you're able to start treatment.
Thank you very much. Dr. Zico?
Okay, I just want to make a comment on the DBS. We had one DBS result that was received on the 8th of June, but there was no action documented. Then another one was received on the 28th of June, and that's the one where the ART was started on the baby. But then we also take note that ART was started a month later after that DBS result was received. So here we're talking about long turnaround time for the DBS results, as well as long reaction time by the health workers. So we've also been informed that there's Program 1 where results are texted as soon as they are ready. So we should not wait for the hard copies. And if we get such results that need immediate action, we need to take that immediate action and not wait for as long as almost 2 months since the first result that was collected. So we've also been informed that the babies or the infants tend to progress rapidly because of the poor immune response. So we need to act very quickly when we get these results, not only the DBS results, but also the viral load results, both in the infants as well as in the adults. Thank you.
Okay, thank you very much, Dr. Zico. And I think Chilenja has emphasized this, that one of the reasons is also lack of documentation. You find that these results could be available, but some of the health workers are not documenting on the official documents, including the patient's file, the child's under 5, the maternal antenatal card as well. So it's always important that we document so that we can assist to improve on the reaction time by health workers. We can now move to the next question, which is, should TLD have been considered for the woman when she was tested positive at 16 weeks of gestation, or initiated ART at 14 weeks gestation? I would ask Dr. Zico to give any thoughts about TLD and the use in pregnancy.
Okay, thank you. We have heard from the Botswana program about the fears of using DTG in women of childbearing age, as well as women who are pregnant. And maybe just to take a cautious approach, at 16 weeks, I would probably avoid the use of DTG and use TLE, especially that's in the first trimester. But at initiation, which was 3 days prior to delivery, which was obviously in the third trimester, I would definitely use DTG, TLD, in order to suppress the mother as soon as possible, seeing that this is a patient who will probably breastfeed the child for at least 6 months. So at initiation, instead of TLE, I would probably use TLD.
Thank you very much. Now, just another thought, Dr. Chanda. In this woman who've been told is quite mobile, and we really don't know where she stays. Would starting dolutegravir in this woman be, what could be your thoughts?
I think the issue, like Zico points out, the issue here is to try and get to viral suppression before actually she delivers. And then added to that, we're saying she's likely to breastfeed for some time, which she has been doing. So then that would be achieved. Now, I don't know whether your concern is whether she's going to access DTG easily. Obviously, that decision can only be made if such a woman can actually easily access DTG, or is at least has access to a center where they're going to provide that. And issues of adherence, yes, remain in the background. I think that should be assessed before we actually move in that direction. But I think it would be a good option. I mean, we'll still come back and ask ourselves several times why she was never initiated on ART to start with. And then we ended up initiating ART 2 days before delivery. Things don't just add up. Yeah.
Thank you very much, Dr. Chanda. Any thoughts from anyone in the community? Chilenje? There's a written question from Chilenje. What are the determinants of HIV-1 infection progression in children? Because we have seen that some kids progress fast compared to others. Dr. Muvyana, any thoughts on?
From the presentation, we saw that disease progression is faster in those who get infected in utero while the baby is still in the mother's womb. So those are the babies who tend to progress faster. But there are also other factors which may determine the disease progression. The mother's disease status. If the mother is not suppressed, has a very high viral load, it means they're probably infecting the baby with a big dose of the virus, so they may progress faster. Advanced disease in terms of immunity in the mothers with very low CD4 counts, they also tend to progress faster. So there are various reasons that may determine disease progression, and those are some of the main reasons.
Thank you very much. I think we have exhausted all the 3 questions. Now we'll give chance for Livingstone, if at all they have got any feelings with regards to the advice that has been given during this session. So Livingstone, Agri, and Robert.
Thank you so much. I think it's good to hear all the contributions that are coming through, that have come through actually. And I think, as it has been mentioned, that it is important that follow-ups are made on this child, and not only the child, holistically, the 2 parents need to have their viral loads checked and ensure that they are suppressed and check for any resistance. And it's for this reason we actually, as a team here, keeping code on our implementing partners, so that some of these gaps can be attended to and through the mentorships. And since this is a case that was just found through the files, that's why we've been finding that most of the information is missing. It wasn't a one-to-one interaction with them. So I think it's been, I think we do appreciate the contributions and the recommendations that have been given, that we need to follow up this family, not only the patient, the child, but also the mother and the father.
Oh, thank you very much, Agri and Robert, for that case. And I think it has brought out a number of issues, both that concerns clinical and also systems that we need to work on. And it has also brought in the fact that a number of healthcare workers have got the inertia to initiate children who are exposed to HIV. I will give the last comment to come from Shonge. Please go ahead.
Good afternoon again. Sorry, it's just a concern. Why are we bringing the issue of TLD in childbearing mothers? Maybe I may have missed something in the past sessions.
Okay, thank you very much. I will still put Dr. Zico on the spot, as he's the one who actually gave the first comments on this.
So the use of TLD is not contraindicated absolutely in women of childbearing age. TLD can be used in certain situations, like in the situation that we have been discussing, in order to suppress the viral load and reduce the chances of mother-to-child transmission. If the mother had started on TLD at initiation, which was 3 days prior to delivery, would have had viral suppression. And of course, we need to not ignore the other aspects of the use of TLD, where we need to ensure adequate contraception in the mother. So if we have ensured adequate contraception in the mother and we feel the viral load should be suppressed as soon as possible, then we can use TLD. So it is not an absolute contraindication.
Thank you very much, Dr. Zico. And I think from the last discussions that we have had, is that should you happen to use TLD in a pregnant woman, you have to ensure that you have got expert advice at hand, because the guidelines, of course, are saying that do not use TLD in pregnant women. So it can only be used under special circumstances, and we are appealing to everyone in the community of practice that ensure that you have consulted the experts should you feel that there is need to use TLD. So with that, I would like to thank everyone for participating and for being with us on early infant diagnosis in HIV. And we'll definitely leave the announcements, I think, with Dr. Zico, who would tell us about the next ECHO sessions. Dr. Zico.
Okay, thank you. So today we've been talking about basically a systems issue. And next week, we're going to be looking at the Lusaka stage reaching the last mile. So we're going to hear how Lusaka is doing their program in terms of HIV management. Mind you, Lusaka province got a prize at the AIDS celebrations in Livingstone 9 days ago. So let's come and hear how Lusaka is doing things so that we can learn one or two things to improve our patient care wherever we are. Thank you.
Thank you very much. And it has been a pleasure being with you all. And special thanks to Dr. Mjana Mbewe for being our expert, content expert today. Thank you very much.